I'm here to talk to you about under-recognized areas in neurodegenerative conditions like Alzheimer's disease or Parkinson's disease. The topic I'm going to be covering today is sexual health, and hopefully I'll be dispelling some of the myths along the way. My name is Dr Alistair Macket. I'm one of the consultant geriatricians here at Addenbrooke's Hospital in Cambridge. So one of the biggest myths by far is that older people don't have sex. Well, evidence suggests that assertion is wrong. We know that people are sexually active into their 60s, 70s, 80s and beyond. But that myth perpetuates for healthcare professionals, and we just don't ask about it in our consultations. So if you think about someone with Alzheimer's disease, we often ask huge amounts of questions about their function, so including how do they wash and dress themselves, their eating, their drinking, their exercise, their mobility, are they driving, are they able to manage high order finances? But sitting in the room is this big elephant where we don't talk about sexual health. And I think it's such an important topic. And hopefully I'm going to show you some of the key issues that you should be raising. So I'm going to talk about my own practice now and what sort of things do I cover when I speak to patients. So the first thing that I do is I talk to them about the physical aspects of sex. So for example, in early Parkinson's disease, we often see erectile dysfunction as one of the early signs. And in women, we may see a fall in libido. For people with Alzheimer's disease, we know that they can have problems with coordination and they may struggle to get into the right position. Other issues that can flag up are to do with their comorbidities. Obviously, this is a disease that's usually of older people, obviously not always. And they can have things like arthritis making sex painful, or they may have postmenopausal vaginal dryness. All of these issues are treatable, so we should be looking and exploring them. The second issue that I explore with patients is around their libido. We know for patients diagnosed with diseases like Alzheimer's or Parkinson's, their libido can change. In a small number of people, they develop something called hypersexuality, where there is an excess of libido and sexual desire. That can be quite challenging. It is seen as either a complication of the disease or sometimes related to side effects of medications like dopamine agonists in Parkinson's disease. More often, we see a fall in libido and the challenges that presents. We also mustn't forget about the person's partner. As you can imagine, the relationship dynamic will change. It may change from a partnership to perhaps a more carer-patient role, and that can be challenging. How do you switch between being a carer to being a sexually intimate partner? You've also got the sheer exhaustion of helping to care for someone. You've got carer stress as well. So it's things that are really important to explore during consultations. And the third and final thing that I explore routinely in my clinical practice is around consent and capacity. It goes without saying, people having sex need to consent to this. But individuals with disorders of the mind or brain, they need to have their capacity assessed. Can they consent to this? So capacity is made up of 4 aspects: whether someone can understand, retain, weigh up, and communicate any decision. It is absolutely vital that this is thought about because physical arousal alone is not consent. And we need to, as healthcare professionals, act as advocates for our patients to ensure their rights are being respected and also protect and support their partner as well. So obviously this can be a very sensitive topic, both culturally and also as an age thing. So we know that people find it very uncomfortable to talk about this, and people may not want to talk about it. The first thing that I do is I just raise awareness and I listen to the patient. Some people are completely open about talking about sexual health then and there. Other people shut down, they don't want to talk about it, but at least you've opened the door to further discussions. They may go away and they may have someone they trust more, so they may have a good relationship with their GP, but by highlighting it, they will go away and they will talk to their GP or their specialist nurse or someone else that they trust to get further advice. Sometimes they come back to you and say, yes, I'm absolutely ready to talk about it. So I think the first thing to do is to talk about it in a non-judgmental, open, sensitive way, but listen to patients. We know that, perhaps 30 or 40% will not want to talk about it with you at that point in time. And it's about respecting those boundaries. But just by talking about it, signposting it, you're already supporting and helping those people. So hopefully you can see over this short talk how important this area is, what huge issues it raises. And please don't ignore the elephant in the room moving forward. As healthcare professionals, we should be raising the issue in a sensitive and open, non-judgmental way. And if you are a patient or a relative or a family member watching this talk, please, please, please feel empowered to talk to your healthcare professional about this issue and raise any questions you might have. Thank you.